and critical illness. The second magic bullet drug for treating COVID is remedesivir. Remedesivir is given intravenous infusion, and we have two regimen. This is the first one, and this is the landmark trial, double-blind randomized controlled trial, addressed the adults hospitalized patients with COVID-19 with evidence of lower respiratory tract involvement. Patients were randomly assigned to receive either remedesivir 200 milligram loading dose. So this is a starting dose, 200 milligram infusion in the first day, followed by 100 milligram daily for up to 9 additional days, or placebo, and the total duration is 10 days. This is the classic protocol. And then we have, and as you see, this is the number of patients. I think 1,000 treated, 1,000, half of them is treated with remedesivir is enough to test the drug. Is this only the randomized control trial? No, we have different studies addressing remedesivir that were assessed in this study. Please don't write on the screen. So these are the different randomized controlled study, and this is the number of patients assessing remedesivir. Again, remedesivir is fantastic, associated with saving life. If there are practice points to be followed, yes, remedesivir may be given as a standard 10 days or abbreviated courses for 5 days, because there was a very nice randomized controlled trial showed that 5 days is working well. So using remedesivir for 5 days as treatment for patients with moderate COVID-19, use remedesivir for 5 days as treatment for patients with severe who don't require mechanical ventilation or extracorporeal membrane oxygenation, ECMO. Consider extending the use of remedesivir for 10 days with patients with severe disease, patients on mechanical ventilation or ECMO. So we can continue for 10 days. Don't forget, the first dose is 200 milligram and then 100 milligram infusion every day. The most problematic issue, remedesivir is not given if estimated GFR is less than 30 milliliter per minute. This is to put in mind. So this is a great problem for the nephrology. FDA recommends that clinicians assess kidney and hepatic function at the baseline and during treatment. The FDA recommends the following: not using remedesivir in patients with an estimated GFR less than 30 milliliter per minute per adult surface area, and discontinuing the use of remedesivir if ALT level increase above or equal 5 times the upper limit of normal. This is why we should monitor ALT every day. So ALT elevation is accompanied by signs or symptoms of liver inflammation or increasing conjugated bilirubin level, alkaline level, or INR, to put all these in mind. FDA reports that hypersensitivity reaction, including infusion-related anaphylactic reactions, have been observed during and after remedesivir administration. Additional adverse events include endocrine and metabolic hyperglycemia, increasing glucose, hepatic. This is why we monitor liver function every day, and some postulated renal toxicity. This is why we monitor kidney function. Don't forget that we don't give this drug if the estimated GFR less than 30. Do we have fresh guidelines? Yes. I advocate all of us to read these guidelines. This is the National Institute of Health guidelines that is updated since a couple of days. The last update is October 9th, so 4 days ago. This guidelines is expressed in 200 pages, 214 pages, including a lot of issues. Again, they categorize the patients. This is for antiviral drugs. Please don't write on the screen. I'm a little bit annoyed by this. So the panel's recommendation for antiviral drugs, according to the state of the patient is not hospitalized or hospitalized makes a great difference. If the patient is not hospitalized or hospitalized but doesn't require supplemental oxygen, the panel recommends no specific antiviral or immune modulatory therapy. The panel recommends against the use of dexamethasone. And look here, A1, the evidence is strong. So restrict dexamethasone or corticosteroid for severe and critical illness, as I mentioned in the beginning. For hospitalized patients, we can use remedesivir for patients who are hospitalized and require supplemental oxygen. Remedesivir 200 milligram intravenous for 1 day, followed by remedesivir 100 milligram once daily for 4 days or until hospital discharge, whichever comes first. And then you can go through the guidelines. For severe disease, dexamethasone and remedesivir can be used together. So, and this is very nice. The panel for patients with COVID who are not hospitalized, who are hospitalized with moderate disease but don't require oxygen, the panel doesn't recommend any specific antiviral or an immune modulatory therapy. There are insufficient data for the panel to recommend either for or against use of remedesivir. But for dexamethasone, they are recommending against. So if the patient has mild disease, don't give corticosteroid. Regarding the issue of remedesivir, we discuss together and we evaluate the patient and assess the comorbidities. And if we assess the patient and we are afraid of progression of the disease, we can give on an individual basis remedesivir. But corticosteroid is reserved for severe and critical COVID. For other drugs, the panel recommends against the use of chloroquine or hydroxychloroquine with or without azithromycin. The level is A1. Don't remember hydroxychloroquine until we have other data. In non-hospitalized patient, the panel recommend against the use of chloroquine or hydroxychloroquine with or without azithromycin for treatment of COVID, except in clinical trial. The panel recommends against the use of high-dose chloroquine for the treatment of COVID. Recommends against lopinavir, ritonavir. Recommend against ivermectin. So all these drugs are of no value.